Good morning, everybody. Like Maureen had mentioned, my name is Ashish Rawal. I'm an orthopedic surgeon here in the area, and thanks for being out here with us today. It's a cold morning, but I think this will be fun for everybody. Although our talk is named Healthy Joints, this is not talk about medical marijuana, so if that's what you're looking for, you've come to the wrong place. Yes. Yeah. Right. A little bit about who I am. I've been in practice for 12 and a half years. I'm a board certified orthopedic surgeon. Also did additional fellowship training in sports medicine, which I'm also board certified for. And you know, a lot of my surgery is arthroscopic shoulder, hip and knee surgery, but also joint replacement surgery for shoulder, hip, and knee as well. When we say sports medicine, a lot of people think, well, he only works with athletes. But the truth is that you know, all of us have active lives in different ways, and we're all kind of athletes in what we do. So my job is to keep people who are active. So age is kind of not an issue when it comes to that. For me, this is a little bit of a homecoming. So for people who don't know me, I practiced here in the Janesville area for 4 years before joining Stoughton Hospital. And I came here from Chicago, where I was in practice 8 years before then. So I was kind of brought along here in Janesville with Dean and St. Mary's to kind of rebuild their whole orthopedic program. And I achieved that goal. I was happy about what I was able to do. And then I had an opportunity up with Stoughton Hospital, working with a great team. And most importantly, it put me closer to home, because I live in Madison, and obviously being married and having 3 young kids at home, spending less time in the car and more time at home with them was really important to me. So I made that move a little less than a year ago, and it's been wonderful. The team at Stoughton Hospital is fantastic. They have a great culture and a great feel. I think most people who come there end up saying that they're kind of blown away by their experience, and that many times in a community hospital, their expectations are lower, but you know, I have high expectations of where I work, and my patients get care, and they've met every single expectation of mine. Obviously today we have Ryan with us here from ATI, and Ryan and I, we got to know each other a little bit starting when I was in Janesville, and really have gotten to, now that I've gotten further away from him, I got to know him even more. But Ryan's done a great job in taking care of many of my patients here with ATI. He does a great job, and ATI is a great organization. Obviously we have one location here in Janesville, but overall they're a pretty big physical therapy company. In Chicago, they're kind of like Starbucks. They're on every corner. But I worked with a lot of people from ATI when I was in Chicago, and it's always been a wonderful experience. So it's always great working with Ryan. He's a great asset to the community here in terms of physical therapy. You know, one of the best things, or the most difficult things, is access. So for a lot of people, being able to get into a physical therapist in some of the bigger healthcare systems can be very difficult. And I think that that ability to get access and that personalized care that you get with him, I think is wonderful. And because I believe that's kind of what I offer as well. So I think we see eye to eye on that, and I think that's wonderful. All right, so why is this important, what we're talking about today in terms of joints? Well, in 1900, our average life expectancy was 47 years. And in 2005, it was actually, that number was, I think, 76 years, but I just popped in on Google the other day and I said life expectancy in the US, so current in 2016, it's 78.69 years. So we are living longer now. The amazing thing is actually we're worse off than other countries. So if you look over here, Canada, the average life expectancy is 82.3 years, and in the UK, it's 80 point something years. So we're not as good as other people, but we're still a lot better than we were over 100 years ago. So we live long lives, so there are going to be things that bother us as we get older. And the population overall is shifting to an older population, and we know that while the population back in, from 1960 to 1990, our overall population in the United States grew 39%, but that older than 85, that increased by 232%. So that larger age population is growing, and we know that with baby boomers that was going to happen. But right now we know that over 50% of people in this country are older than age 35, and over 25% are older than age 55. So we know we have that trend in shifting towards a older population because of the baby boomers. And a popular term that I use is we have boomeritis. So we're finding now as all of us get older, we still want to stay active. We're not like we were generations ago where we said, okay, as we get older, we know that we're just going to live a sedentary life and not do anything, which we may have seen from our elders, but we don't want to live that life. We want to live a life that we're just as active as we are when we get older as we were when we're younger. And then with that came a whole trend of injuries we never saw before because people were never active to these ages. So that's kind of an interesting thing to kind of see that. And so our goal today overall is, one, what is a healthy joint? Two, how to identify when a joint becomes unhealthy? And three, what can you do for an unhealthy joint? And most of our focus is going to be on arthritis, just because that's what we're going to deal with as we all get older. So a healthy joint on the right side shows a picture of a joint, and what we can see here, if I stand here just for 1 second, is that you have a nice lining to the joint. The fluid stays in there. You have a nice smooth cartilage surface kind of throughout, and nice healthy fluid. And that fluid composition really makes a bit of difference, because when it's good healthy fluid, it's like fresh 5W30 you put into your engine. It's nice and clear. But as our joint gets unhealthy, what happens is now we see that you get a lot more inflammation and swelling. The ends of the cartilage start wearing out, and actually this fluid composition starts changing and starts looking like that gunky oil you take out after 5,000 miles. So that's what happens as our joints become unhealthy. So all of us have everyday aches and pains that we deal with. Some are just associated with because we overdid it. We did something maybe that we're not used to doing or haven't done very often, and that can cause some aches and pains. But some are due to arthritis, and those are the pains that are going to kind of stay with you and not go away after some rest. And arthritis, as we know it, really is just, the term means it's just an inflammation of a joint that results in pain, swelling, and stiffness. So what are signs that we know if it's an injury versus arthritis? So early on, many times you're going to have kind of the same symptoms. So if a 30-year-old twists his knee, or an 80-year-old twists their knee, they're going to have some of the same symptoms, which is going to be swelling, stiffness, and pain in the joint. And the question is how do we then determine if it's just related to an injury or if this is related to arthritis? Well, one of the main signs is the pain persists. If you have that pain and it's just not getting better for 2 weeks, you said, okay, I've rested this, I've taken some ibuprofen or Tylenol, and I've iced it, and I've kind of watched my activities, but the pain's not going away. Well, then you need to start thinking, is there something else going on? And that's when seeing a physician, or if you or a physical therapist now, that's something that we can. State of Wisconsin's nice that we have direct access, that many times you can see a physical therapist without needing a prescription, and they're a great resource to be able to kind of figure out what's going on for you. So other thing is, what's common is all of us get older, we become weekend warriors. We do our regular jobs during the week, and then on the weekends we're doing a lot more strenuous stuff, whether it be sports, whether it may be yard work, may be wrestling the grandchildren, whatever it may be, but we find that we tend to overexert ourselves on weekends, and that can then lead to injuries as well too. So ways that we can kind of determine acute injury versus a chronic injury, and chronic injuries when we're looking at arthritis is taking a look at, is it just a sudden pain from a certain activity, or is this just something that, hey, every day with my routine activities, these symptoms happen to me again and again and again. Factors that contribute to arthritis, we know age. We know that as we age, more of us will have arthritis. If there was one thing that I'd say is the most important thing that I can give to you today, is that weight is one of the biggest contributors to arthritis, and I think that changing your weight for someone who's heavy can make a tremendous benefit for them as a patient. Previous injury, so patients who come and see me, they say, listen, I remember 40 years ago I played hockey and I did something really bad to my knee. They told me back then I had some torn cartilage, and now my knee's like this, and that can definitely make a difference. Occupational hazards. There's some people who do really strenuous work in those occupations really can take a toll on joints. I've taken care of a lot of Janesville firefighters, and some of them have the worst knees that I've ever seen in my life, and it's just the nature of the work that they do. And obviously, if you had a previous illness or infection in that joint, that could lead to early arthritis as well too. So we know that our body's going to change as we get older. There's nothing we can do about that. And that chance of arthritis developing increases, obviously, the older we get. And believe it or not, by age 65, half of us will have arthritis in some joints if we start x-raying all of our joints, but that doesn't mean necessarily that it's bothering us. It's a point where it becomes symptomatic. And so that's always important too, is to say, okay, I may have arthritis in a joint, but if it's not bothering me, we don't necessarily have to do anything about that. So we know 60% of people who have arthritis are women. Excess weight can contribute to that and cause the progression. And then we talked about occupation as well. Anything you're doing, repetitive squatting, heavy lifting, that can all cause acceleration of that arthritis process. So why does arthritis hurt? Well, that smooth cartilage that's on the end of the bones that we saw in that previous picture, that breaks down over time. And as that breaks down, the bone underneath it is exposed, and then you start getting that rubbing against each other, and that causes the joint to get inflamed. When the joint's inflamed, our joints are usually dumb, and they don't know anything besides we got to make more fluid because it's trying to protect itself. And so that's when you start seeing that swelling that occurs with that. Common symptoms that we talked about, joint stiffness is usually the biggest one, and most people will say, if I sit for an hour and I get up, hey, you know what, my knee or my hip is really stiff and it's painful, but as I walk maybe 10, 15 minutes, it starts loosening up and feeling a little bit better. And that's a very common sign for arthritis, is that as the joint gets warmed up, it starts feeling better. I see a lot of people nodding like, yes, we know what that feels like. And so the thing is that obviously swelling can represent other things like an acute injury, infection. So obviously if that stays persistent with you, then that's something that obviously you should get addressed by a physician. Arthritis, the most common joints that we know that I take care of obviously is the knee, hip, shoulder, and elbow, although they can happen anywhere, ankle. Many people see it in their finger joints as well too. So it can develop in multiple joints, and it really can make your daily activities very difficult. And a lot of patients that I see, by the time they come to see me, their quality of their life is significantly affected, where they have to plan their day around how their joints feel. And they have to say, okay, well, when I go to the store, I got to make sure I park in a certain spot. I know I got to go through the store in a certain path, and I got 15 minutes to get it all done. And if I don't get it done by then all of a sudden this is going to become a real problem. And so then basically that arthritic joint takes control of your life and doesn't allow you to live your normal life. So what are questions that we ask as doctors when we see patients with arthritis? Many times it's going to be asking about that history. When do you have pain? When did it start? Did you have an injury, etc.? Also, we're going to be examining those joints, taking a look, swelling. Is there a loss of range of motion? Is this painful? Also getting things like x-rays and other imaging tests to figure out, is it truly an arthritic joint? So x-rays are probably the #1 test that we'll look at to see arthritis. Many times patients will come to me with an MRI, which is great. It can really help take a look at really the fine detailed structure, but many times the best test is just a simple x-ray. So patients will sometimes come with me with an MRI without an x-ray, and I say, well, let's get some x-rays. And they say, why, you got an MRI? Well, sometimes we have to see the forest for the trees and kind of take a step back and take a look at the big picture, and x-rays really can help with that. So two main types of arthritis that we talk about. So the main arthritis that we talk about here, and when people talk about arthritis, is osteoarthritis. And that's your run-of-the-mill average arthritis from wear and tear, age, et cetera, kind of the things we've been talking about. And that's very different than rheumatoid arthritis. Rheumatoid arthritis is a chronic autoimmune disease, basically where your body is attacking the joints and then causing destruction of the joints. And that's a very different phenomenon altogether. So common joints that are affected. Excuse me 1 second. I'm trying to get over a cold here. So there's a difference because we have weight-bearing joints that we walk on our legs, so therefore our hip and knees are weight-bearing joints. But then joints like our shoulder and elbow are non-weight-bearing, so they don't take as much brunt of it. And because of that, people tend to ignore arthritis in those joints probably a little bit more longer, because if your knee hurts or your hip hurts, you feel it every single time you walk and your life is impaired. If your shoulder is arthritic, you may just not use your arm as much, but your mobility is not going to be limited, and so you may just deal with it longer. So symptoms for hip arthritis, how do you know that you have an arthritic hip? The most common thing we're going to see is groin pain. So 9 times out of 10, if someone's got an arthritic joint, they will tell me, I have pain in my groin. Usually, and sometimes patients will have pain on the side of their hip, which we call lateral hip pain. Very infrequently is pain in the buttock or low back associated with hip arthritis. Those are usually other problems. And so that's what I tell many times, that if you don't really have groin pain or pain on the outside, it may not be your hip at all. And that's the thing sometimes that can be confusing, is back problems and hip problems can be very interrelated. And then we have to figure out which one's causing pain for you, because if we don't treat the right one, then you're not going to get better. Arthritic knee, so pain, limp, loss of range of motion. But the interesting thing is, if you have an arthritic knee, you may start having hip pain and back pain as well with that too. And so it's important that when we look at someone who comes in with hip and knee pain, that we take a look at the other joints and make sure, hey, is it something else that's causing this to hurt? And sometimes I'll have patients that come in with knee pain and we x-ray their knee and everything looks fine, examine their knee and realize that it's actually their hip that's causing them trouble, but they're feeling the pain mostly in their knee. Shoulder arthritis. With arthritic shoulder, one of the things I see very common is people have pain at rest. They're not doing anything. They're just sitting there and their shoulder hurts. And the other complaint is that they can't lay on that shoulder when they're sleeping at night, and they're not able to get a good night's rest. So that's a very common finding that we see with that too. And just like we said, hip and back pain can sometimes be intermingled. Same with the shoulder and neck. And so sometimes those problems can overlap as well too. So sometimes we have to do some detective work and figure out which one is truly bothering you. So treatment of arthritis. Well, in weight-bearing joints like our hip and knee that we talked about, obviously weight loss is one thing that we talk about very commonly with patients, because we know that, and I'll get to this slide in a second, but basically for every extra 10 pounds of weight you carry, it's 50,000 pounds of weight on your knees for every mile you walk. And so the main point of that statistic is even a small weight loss of 10 pounds can take a significant amount of weight off your knees and really make a difference in your overall life. Modifying your activity, so saying, okay, you know what, my knee hurts every time I go up and down stairs. Well, then maybe we need to figure out what's a better way at home to say, okay, I have stairs at home, but I'm going to try to do all the work I need to do upstairs before I come downstairs and try to avoid going up and down, up and down. So to a certain extent, modifying activities, modifying your exercise plan. A big part of conservative treatment is physical therapy. There's a lot of people who have joint arthritis symptoms and they're just starting, but there's many times that someone like Ryan could be really helpful in kind of keeping that at bay and then avoiding things like surgery early on. So I think that's a very helpful thing. And you know, what's interesting is I'll have a lot of patients who come and see me, and Ryan's probably seeing this too, but they say, well, you know what, I really don't believe in physical therapy. And I tell them, well, that's interesting. And I tell them, but I'm recommending it because I believe in it. I'm not just telling you because, hey, you know, we're going to try this, but obviously I see the success and the importance of physical therapy, and if it wasn't for physical therapy, for me, my career would be a disaster. All my patients after surgery need good physical therapy, and that's really important. And it's really important for people to potentially avoid needing surgery as well too. So I think that's a really big help. Medications by mouth, and then we talk about injections as well too. So we talked a little bit about weight loss, and losing 10 pounds is 48,000 pounds fewer on your knees for every mile you walk. So this is a very effective first-line treatment that we recommend for a lot of people. Activity modification, we talked about avoiding stairs. If you're a runner, not run. And then kind of changing your exercises to a little bit more lower impact. Physical therapy, a lot of things that Ryan can help you with, and I'll let him go over more of that with his talk. Medications. So medications, simple anti-inflammatories, Advil, which is ibuprofen, Aleve, which is naproxen. Those are anti-inflammatories. By decreasing the inflammation in the joint, the pain decreases. Tylenol, for many people that they're not able to tolerate anti-inflammatories either because of other medications or if they have kidney problems or their stomach's not allowed to tolerate that, Tylenol can be helpful for many others. Celebrex is one that we use, but we're seeing that used less and less because there's been some studies that people who have chronic heart problems, a medication like that may not be the right answer. Another popular one patients ask me about is, what about glucosamine chondroitin sulfate? That's an over-the-counter supplement that is very popular. And basically, those ingredients, glucosamine chondroitin sulfate, are the ingredients of normal, healthy cartilage. So someone came up with a brilliant idea. Well, if I take that by mouth, I'm going to grow cartilage in my knee. And I remember one of my previous colleagues says that makes about as much sense as if I'm going bald, I should eat a handful of hair, and I'm going to grow more hair. And that being said, the results have been mixed in the research studies that they've done. The reason it's very difficult to study is because glucosamine chondroitin sulfate is not an FDA-approved medication. It's just considered a nutritional supplement. So it doesn't go through the same rigorous guidelines as other medications. So for example, when you go to any pharmacy and you buy 500 milligrams of acetaminophen, Tylenol, every store, every brand needs to have 500 milligrams of that medication in there because it's an FDA-approved medication. There's no rules like that for this medication, so you can go to 20 different stores and they will be completely different at every single one. So you're not comparing apples to apples when you're doing the research, and that makes things very difficult. Certain medications can be affected by these, and then if you have a shellfish allergy, you're not allowed to take them. Kind of the main point I tell patients is that if you're considering taking it, get a big supply from Sam's Club or Walmart or wherever. Try it for 3 months. If it's helping you, keep taking it. If not, quit wasting your money. It's a multi-billion-dollar industry, so there's a lot of people making money off this. Injections really come in two flavors. Cortisone injection and what we consider viscosupplementation injection. The main workhorse is cortisone injections. They have shown probably the best track record of what can help. It helps decrease the inflammation directly for you. And usually we inject it with a numbing medicine, so that makes it a lot more tolerable. Most people come in with some horror story that someone had an injection and it was like the worst pain in their life and they're concerned about that. And I'll tell you, 9 out of 10 people leave my office saying, hey, that wasn't as bad as I thought it was going to be. And it can really provide a lot of relief. But we know we can't do that forever, but it can be a good first starting solution for people. Viscosupplementation injection, so we call that hyaluronic acid. So basically hyaluronic acid is a good normal ingredient of your joint fluid, and we're trying to improve that with these viscosupplementation injections. So it's almost like an oil change where we're trying to say, okay, that oil is old and gunky. If we add some newer oil to it, that this is going to be better for it. So oil change, lube job, whatever you want to call it. And so the benefit of this is that this is a little bit more natural. than a cortisone injection, so patients prefer that. We used to have to do this as 5 injections where you'd have to come in once a week for 5 weeks to get your injection. Now many times we're able to just do this in a single injection, so we don't need to have patients coming in again and again. The unfortunate part about this is that over the years, all the research that seems so promising about these injections has slowly dwindled away. And now the research is really mixed, and we don't know if these are as beneficial as we thought they were previously. So now, I don't tend to recommend these much as first-line treatment for patients. If you've tried cortisone and a bunch of other things, and they're like, okay, I really want to try every single possible option, then yes, I think this is something to consider. Also, if I have someone who's come see me and said, listen, I've had these injections previously, and they work great for me, then by all means, continue what works for you, but not something that I'll use as a first line. Oh, and also for viscosupplementation injections, these gel injections, they are only FDA approved for the knee, so we really don't use them for hip, shoulder, etc. If we do, it's considered an off-label use, and occasionally you have a patient comes and says, I really want to get this done. We can do it, but we have to tell them it's not FDA approved, and many times insurance companies won't cover it because it's an off-label use. Next is arthroscopic surgery. So now we're going to go into the surgical option. So with people who have, very mild cases of arthritis, arthroscopic surgery, which is minimally invasive, 2 small poke hole incisions. I'm able to look with a camera and then use instruments to help clean the inside of the knee, done as an outpatient procedure, can be very effective. And for someone who's got milder arthritis, who's really tried everything else, and this has, and it hasn't helped, this can be something that's a possible treatment. And who wouldn't prefer a less invasive treatment that is going to get you back up on your feet and you don't have to stay in the hospital? I mean, I think everyone would prefer that, but not everyone's a candidate for this, but this is always part of that conversation. So who's a candidate for a joint replacement? I think the first point's really important, is that really before we consider joint replacement, we have to really say, did we try all the things non-surgically, and did we optimize it? Did we do weight loss? Did we do medications? Did we do physical therapy? Did we do injections? Have we really tried all those things before we say, hey, we're going to do a joint replacement? And the best candidate is someone who, like we talked about, they have that daily pain in their life where their life revolves around that painful joint, and that they have to manage their day based on if their joint cooperates or not that day. And specifically when we talk about knees, the stiffness, instability, and then many people will have quite a bit of a deformity where they'll either be bow-legged or knock-kneed significantly, and that also affects their daily activities. So let's talk, we're going to talk about all the main joints, knee, hip, and shoulder, but for knee replacement, joint replacement is basically where the end of the bone, of the thigh bone, the femur bone, top of the tibia bone are replaced with metal and with a layer of plastic in between, and that creates a smooth knee joint. It's something that's done commonly in the U.S. 600,000 every year in the United States are performed. It's considered the gold standard today. We have great long-term data showing that this is a very effective solution for knee arthritis. And the technology is really growing, and there's a lot of great new technology techniques that have really improved the recovery and the outcomes of a knee replacement. But still, regardless, it's a big deal. It's not a small undertaking for a patient. And I really tell patients, if you're going to go through a joint replacement, to a certain extent, it takes a village. It's not something you can do by yourself. You need help of family, friends, etc., to get through this. Just like on my end, it takes a village. I have a huge team behind me in my office, in the operating room, in the hospital, and then all my physical therapy colleagues. I mean, it's a huge army of people that really helps get people better. But patients on their side need an army of people too to really have that good result. So what the technique that I really enjoy for my knee replacement that I've started using just this past year is called a conformist knee replacement. And that's a truly custom knee replacement. They're the only company that can say it's a true custom knee. All the guides that are made to help the cuts in surgery are custom made, and then the actual prosthesis is custom made. And so you may have people that say, hey, I got a custom knee, but if it wasn't a conformist, it truly wasn't a custom knee. They may have had custom cutting guides, but then they use a standard off-the-shelf knee prosthesis. So you have to be careful of what you hear. But I think if this video works here, this will kind of show you how this works. So with the conformist system, what we start with is first getting this just shows a knee that all the cartilage there is worn out. And it starts by, we get a CT scan that goes from the hip through the knee and down all the way to the ankle. And that data is sent directly to the engineers at Conformis in Massachusetts. And based on that, they're able to look at that CT scan and say, okay, well, this is what their knee looks like now. This is what their knee should look like. And what they do is they match these, what they call J curves. So you can see there's 3 different curves here. And so they basically use their software to then basically create a knee that's made just for you. And this is 3D printed for the mold for this, and the prosthesis is then cast from that 3D printed mold. And so every single prosthesis has its own serial number that's just made for that patient, and all the guides are made just for that patient. And that gets then shipped to the hospital, and on the day of surgery there's a nice box that's got the patient's name on it that's just for them. But they use the same, for both sides of the tibia. So you can see where the green is, that's a unique shape, and everyone's going to have a different shape to that, and then that gets custom made. And so that's a really neat technology. So my experience is for 10 plus years I did standard off-the-shelf knee replacements. I thought I did a really good job at them. But if I really look closely, I could say, 1 out of every 5 people did okay. 4 out of 5 people did really well. 1 out of 5 did okay. And so I was introduced to this technology as I started at Stoughton. I was very skeptical. I, like many other people, thought, oh, this is just a gimmick. This is just a way to get patients in the door. And I went through all the education. I talked to a lot of other surgeon colleagues who I trust and respect. And then I tried this in a cadaver lab, and it really made sense to me. The company answered all my questions, and then I started doing them. And so over the past 9 months, I've done around 50 of these, and I could not be happier. And I could not imagine going back to a traditional knee replacement. So there's a lot of things that when sizes don't fit in traditional knee replacement, you have to start twisting and turning and trying to make it fit. Well, when it's a custom fit, it just fits. So
what's the lifespan then of after the replacement joint is placed?
Right. So the main question is that what's the lifespan of these materials? So when they put these materials in a tester, it can last 15, 20 plus years. Now, what affects that longevity? It's usually not the materials. The materials themselves will last, but if we see early breakdown, 1 depends on how well was it put in. And 2, obviously, is every patient's bone density. Because if we see a source of failure, many times the prosthesis can loosen over time. And that's because it sits inside a human body. And that's the weak link, is us as human beings. But the nice thing about this implant is that it really allows us to put it in the right way. So ways that I may be fooled by the human eye thinking, oh, this is the right way, well, now I have a double check. I have a computer guided algorithm telling me this is the right way to put it in, and that this is the right appropriate shape for you. Because if we took 100 different cadavers and opened up their knees, they're all going to be different. No one person is the same, right? It's just like if I said, I'm going to buy a size medium t-shirt for everyone in this room, and let's hope it fits everybody. That's not the case, right? And so to me, this technology makes really a lot of sense because, in the end, I just say it just fits. And what we've seen on the backside of it is I've noticed my patients' pain after surgery is less than off the shelf. Their recovery of their range of motion is less. They tend to have less bleeding after surgery. We're seeing shorter stays in the hospital. So a lot of benefit to the patients. And the long-term benefit, which we haven't seen yet, is in the long run, we hope that because we're putting these in better, that they're going to last longer. Now, these have been out on the market for 10 years, and so we don't have that 20-year data yet, but overall, worldwide, 75,000 of these have been put in. So it's not something that we would consider experimental or something that we're trying. This is a proven technology that really works. Hip replacement. So hip replacement, if you take a look on the right side, you see kind of a before and after, but there's kind of 4 pieces that are involved in a hip replacement. So one is the acetabular shell. That becomes your new socket. The femoral stem is what goes down into your thigh bone. And then there's a metal ball and then a plastic socket here. So it's basically the same as a knee replacement. It's a metal with a sandwiched plastic in between. And believe it or not, this is an older picture that I have here, but we're using ceramic now instead of metal heads for almost everybody. The wear characteristics are much better and tend to last longer. So here's just an x-ray of what someone with a hip replacement looks like. Shoulder arthritis. So that again, x-ray examination. Like I said, for many people, this one sneaks up on them because since we don't walk on our arms, we don't necessarily realize we have shoulder arthritis right off the bat. So we can see here in this picture, the space between the ball and socket's decreased. We see this big spur down here. We call that a goat's beard, and that shows us that we have an arthritic joint. So the old way that we used to do shoulder replacements is that there would be, just like in a hip replacement, this big stem that goes all the way down in the bone with a metal head, and then there's a plastic socket. So that's version 1.0, and that's what I used to do, and a lot of people still do this. So then there's the evolution 2.0. So instead of a bigger stem, now we got a much shorter stem. So we're saving a lot more bone, less invasive, quicker recovery, and that's what this looks like. And that's version 2.0. And then, again, this is showing 2.0. This is 3.0 now.
Oh, wow.
So much smaller. So if you take a look at the x-ray here, really small. Yep. And we have some information back there. But this has been my go-to for shoulder replacements, and I think that it is a fantastic prosthesis, great for patients. And also for this, we use a CT scan and do preoperative planning to kind of make sure that we're getting the right size prosthesis, putting it in the right way. So that technology out there can really help us. So overall, in conclusion, and I'm going to try to stick under the 40 minutes here, like I promised Ryan. So we know that despite what we do, arthritis is going to potentially sneak up on all of us. It's something that we can't escape, kind of like paying taxes every year. But many times it's got a slow progression. And because of its slow progression, we can do a lot of conservative treatments, like we talked about, including physical therapy. And then we know that if your symptoms persist, make sure you have a professional address them. So whether that be a physician or a physical therapist to get that ball rolling, that's important. And we know that there's a wide spectrum of treatments that exist. I'm a surgeon. I enjoy doing surgery, but if I can find for my patients a solution that doesn't involve surgery, that makes me even happier. Because in the end, that's what I would want for me, that's what I would want for my family, and my patients are my second family. And so if we can do things and make things better without having to take that route, that's obviously the best thing. So that's all I have to say. I appreciate everybody's time, and I'll let Ryan take over, and then we can do questions afterwards.
Thank you, Dr. Rawal.
Thank you.
A lot of good information there about really what happens, and I think it's very important to make sure that you kind of understand what is going on in the joint, and that's kind of what he went over there. But the next part about it is what are some other things we can do besides some of those injections, besides going to that last resort of having to do the surgery. And my part is the physical therapy part. So physical therapy can address a lot of things. A lot of people just think that physical therapy is just doing a bunch of exercises. But for the most part, when somebody starts physical therapy, we do a full evaluation of what is the problem. We try to find the source of the problem. And like Dr. Rawal said, sometimes it's a little bit, we got to find where the source is coming from, and we have to check the joints above and below. And sometimes the knee is contributing to the hip, and the back is contributing to the hip. And in physical therapy, we have to address all of those things. And so we also address not only what's going on with the joint, but we're going to address muscle flexibility. We're going to address the capsule of the joint, and that's going to be the ligaments that hold the joint together. We're going to address, how that joint moves and make sure that it's moving correctly. And that's really, I think, what people benefit from the most is they have years and years of what's been going on in this joint, and that joint just isn't moving correctly. And so the muscles, the ligaments, and the tendons, they all join in to create what that joint and how that joint is going to move. And so we start to get into the details about what do we need to do to make that joint move better. And so I do have a handout that has a couple of exercises that are going to go over hips, things for the hip, things for the knee, and things for the shoulder. But more importantly, I think it's best to understand that before we can do a lot of these things, we have to make that joint work better. And that involves mobilizing the joint. That involves just making sure the mechanics and everything works well together. So there's a lot of hands-on work that goes in before we can get to some of these things. Whether it's using massage therapy to improve the extensibility of the muscles so that we can achieve proper joint motion, whether it is using some other techniques along with stretching. There's lots of different stretching techniques that can be utilized as well. We're going to go over just one today that's probably the most common and the most easiest to do. And so without further ado, we'll kind of get into those. So if did anybody not get a handout they've got that has the exercises on it? It looks like this. It's just a black and white one. Did you need one?
I don't have one of those.
One of those, that one isn't going to be what I go over here, but that one we have extra copies of those over on the table over there. So if you look at the very first exercise on top of the page there, we're going to address the knee first, okay? And so the first knee exercise that I have there is just stretching your hamstrings. And this obviously goes along well with making sure that our joint is able to achieve its full straightened position. And I think that is probably one of the most important parts when we're talking about the knee. If our knee isn't straightening all the way, that's going to be a big problem that leads to pain within the joint, but then also that can lead to back pain as well. If we're not able to walk with that knee fully straight, we're going to have some compensations that develop, and it usually comes in the form of in our lower back. Okay, so I will demonstrate. It is important to remember, though, when you are embarking on doing some new type of exercise or stretching technique, this should not be painful. Okay, we want to make sure that these exercises, you're going to feel some pulling for sure. Okay, but we should not have sharp pains when we do any exercise or any of these stretches. Okay, so if you are experiencing that, one, either maybe we need to recheck and see that we're doing it the right way. Two, maybe this isn't the exact stretch or exercise for you. That's where I come in, visiting a professional that can help make sure that we select the right ones for you. There are lots of options on stretching one muscle in different ways, different body positions that can make it easier for you. So I just have a few options on this piece of paper that we'll kind of go through one by one. And if you do have questions, we'll take them during or after. If you have specific questions, we can talk about things after the presentation as well on an individual basis. So the first one I use is, again, stretching the hamstrings. And the hamstrings are the muscle on the back of the thigh. I always like to use one of these straps here. This is a stretching strap that is specifically for stretching, but you can use a long piece of rope, you can use a belt, or more commonly that people like to use and have around the house already is a dog leash. That tends to have a nice loop that helps us put it around our foot or body part if you've got one of those laying around. Better be careful though. Once you get that out, the dogs tend to go crazy. So you maybe gotta get it out when they're not around or looking. So the first one is I'm keeping my knee relatively straight, and then I pull this up until I feel a nice pull on the back of the leg. And here, and there are instructions on the sheet there that shows you we want to hold that for 30 seconds. The reason we hold these stretches for 30 seconds is that there is an initial resistance to stretching. Your muscles, they want to tighten up. As soon as you try to stretch them, you're going to feel like, oh, that may not feel that good. But we have to get through that initial reflex that happens with every muscle and hold that for an extended period of time so that natural reflex goes away, and then we can get into actually making the muscle longer. Okay, does that make sense? Okay, so that one's pretty simple. The next one is a little bit more challenging. I do have two options on the piece of paper there for you. One may be better for you depending on if you have some lower back issues or if you just have trouble grabbing an ankle, okay? So the first one I have on there, you would use this on the side of your bed. We always bend the opposite knee, but here we can drop one leg off the side of your bed, or if you happen to have a fancy stretching table like I do here, that works as well, but not too many of us have those at home. So if you can't reach your ankle here, you can give a little bit of pull back. You have to be careful about your shoulder. But this one you're going to feel in the front of the thigh here. You might even feel it in the front of your hip. If that hip is the focus of your problem, you may have some stretching in the front of your hip there. And again, you hold that for 30 seconds. Now, like I said, I've got another option there for you. This one can cause some lower back pain if that's really one of the things that's going on with you. And so we can also take and put this strap around our ankle and lay on our side. So that's the third stretch on the sheet, the second option for this same muscle here. And you can bring this up and around your shoulder like this if you've got a nice long rope. And that way it's a little bit easier for your lower back, but you're still able to achieve this nice stretch in front of the thigh. Okay? All right. Since we're up doing like hip and knee at the same time, our next one is just a mobility exercise for our hip. And that one we're going to lay on our back with both knees bent. And this one we're going to work on just working our leg out to the side. Now this one can be, you can hold this as a stretch for 30 seconds, or if that's not comfortable for that hip, sometimes these are going to be the ones that if you've got some groin pain, this is the one where you're going to feel this stretch kind of up into the groin area. So you kind of hold that for 30 seconds, or you can just do back and forth nice and slow, nice and easy, trying not to force that hip through any range of motion that it doesn't want to go through. But the more you do with that one usually tends to loosen up. Okay? Yes?
What's the benefit of that one?
That one is going to be for your hip. Okay? So a lot of times when we have that hip arthritis, we tend not to be able to do one of these. Okay? Putting our shoe on tends to be very difficult. And so that motion right there is one that we tend to want to loosen up first. And so being able to get that knee out to the side so that we can then go up like that is one of the first steps in being able to loosen that up. Okay?
And number two, where's your building located?
Do you know where, over by Menards is where our clinic is. It's right next to Firehouse Subs.
Thank you.
Yeah, no problem. So the last one on that first page there, this one is also for the knee as well. We're going to be stretching the calf, okay? And because we have many muscles that do cross the knee joint that could prevent us from straightening our knee all the way, the calf is a really important one because that one crosses the knee joint as well as the hamstrings do. So we want to attack that knee from both the lower part and the upper part. So the calf stretch that we have on there, usually you can hold on to a chair or a countertop, and then you're going to put the one that you're going to stretch behind you, making sure that your knee is straight and your foot is pointed straight forward. Those are the two most important things there. And after you achieve that position, then you just kind of lean forward a little bit until you feel a nice pull right below the knee here. Okay? Any questions about that one? That one usually just feels good if you've been standing for a while or out shopping. All right, the next one at the top of the second page, this one is about stability, okay? And stability is really important for both the hip, the knee, and your ankle, and it even affects your lower back as well. So a simple one-leg balance and trying to improve on how long you can do that for can really help you in the long run. I know one of the things as we age is we lose flexibility, but we also lose balance. There's a lot of things that go into losing or our balance not being as good as it used to be. So this is also a good exercise to help with once we've started to loosen our knee up, once we've started to loosen our hip up, what can we do to make it more stable? And this is one of the things that's, you don't need any real equipment to do that. And my recommendation is start with something that you can hold on to, and then you lift one leg up and you've got your stopwatch or you've got a second-hand timer, and you just try to go as long as you can with as little help from your countertop as possible. Okay? You're working on both your hip, your knee, and your ankle stability all at the same time. And as you get better at it, go longer. Okay? Try to work up to a minute. Try to work up to 2 minutes and do both sides for sure. Okay? So the next one, repetitive squatting is not typically one thing that helps knees out, but we need to be able to strengthen. We need to be able to strengthen our quads. We need to be able to strengthen our hamstrings, strengthen our glutes. All of these muscles need to be strengthened once we start to improve mobility. And for bang for our buck, just sitting in a chair and rising from that chair is one of the best exercises we can do, as long as we're not having sharp knee pain or it's not causing us that groin pain that might be a symptom of our hip that we're having. So just a simple exercise. You start sitting at the edge of your chair, and from that sitting position, you then just stand up, make sure you straighten your knees all the way, bring your hips forward, and then go back down. And we want to make sure that we can do that in a way that we are not losing control on the way down. Okay, and what I mean by losing control is we're not plopping into that chair. You can use your hands if you need to, but over time, try not to use your hands for help because we want to make our muscles of our legs work the most. If for some reason you can't, or you are not strong enough to be able to get up out of that chair without using your hands can help, but maybe elevating the surface, so maybe a taller chair, or insert a pillow underneath you as well. And that way you can then eventually, as you get stronger, you can remove that pillow or use less of your hands. Okay? The other thing you would also want to, with that one, as you are standing up, if we have some weakness in our glutes, our knees tend to come together. Okay? And that's one thing that we want to watch for. Okay? If our knees are coming together, that means there is some twisting going on at that knee, and knee twisting is not one thing that's going to help that joint that's already irritated like us more. So if we can keep our knees straight over our feet and straight over our ankles and not let them go in or out, that's going to give us the best results and least amount of discomfort while we're doing that. Okay? So moving on to, I got two for the shoulder. The first one would be the second to last one on the second page, is bringing your arm across your chest. Okay? And I do have an arrow on there you can see by the left shoulder, we want to keep that shoulder down as we bring it across. And you can use your hand to kind of pull across your chest like this. Okay? And this one we hold for 30 seconds as well. We don't want to have our shoulder up in our ear. Okay? The more we have our shoulder up in our ear like this, typically the less effective it's going to be. We should feel this stretching and pulling coming across this part of the shoulder. Okay? And that's an easy one to do anywhere. Any questions about that one? Okay. And our last exercise that I have for us, you would need a corner or in your house or a doorway. And this one is really important for shoulder function because most of us, we tend to either sit in front of a computer, we sit and watching TV, or we're driving a lot. And all of that tends to lead towards this slump forward posture. Okay? And our shoulders do not function well in this type of posture. So this last exercise, this last stretch is meant at bringing those shoulders back and opening our chest up so that we can have better shoulder function. One of the things I usually do with my patients just to illustrate that is try to reach your arm up with bad posture. Well, that's about as far as I'm going to get before my shoulder's just not going to go anywhere. But if I take my shoulders and I bring them back like this, then I have a lot more range of motion there. And that gives room for all the rotator cuff tendons. That gives room for everything just to function better and have less chance of deteriorating any impingement problems that can happen there. So as far as the stretch, in the doorway, try to have you can have your hands up higher or your hands down lower, depending on what's most comfortable for you. Okay, and then typically we just lean, have one foot in front of the other, and then we lean forward into the door frame. Or if you're in the corner in your house somewhere, just leaning a little bit forward until you feel you're stretching in through here. Okay, we shouldn't really be feeling any sharp pains with this. If you do have a very limited range of motion with your shoulder, this one is probably not the one for you. Okay. Adjusting your arms to a lower position is one that would be much more beneficial. So you can do it down here if this position is not one that's going to work for your shoulder. Okay? Any questions about anything? Well, that kind of concludes my handout as far as some of the exercises and stretches that would be beneficial for you to kind of keep your joints flexible, mobile, and healthy. Obviously, there are vast number of exercises that can be used to do these things, and these are just kind of some of the ones that I feel are most commonly used, most important to kind of get the most bang for your buck when you're doing things at home. Yes?
Can you recommend any sorts of activities that help maintain joint strength and flexibility, such as yoga, Tai Chi, myofascial release therapy? Do any of those contribute to helping maintain your joints?
Absolutely. Within our sessions, we do a lot of myofascial release. There are exercises that I do that also coincide with poses or things or stretches that you would do in yoga, or exercises that you would do to strengthen your core along Pilates. So within physical therapy, we use a lot of those techniques, but those are also great classes to take. You just have to definitely be aware of what your limits are when you're going to these classes. If you do have an issue, talk to the instructor before class to make sure that, hey, I've got this issue. Can you keep an eye on me during the class and make sure that I'm not going to do something that could hurt me? And they can usually give you a modification for all of those things. But all of those things are great, great things to help. The other thing that most beneficial that I recommend to a lot of people that you do have access to here in Janesville is a pool. Okay, and water aerobics, just walking in the water, just getting in the water can help give people a lot of relief and also strengthen you at the same time. Yes?
What's the myofascial release? I've never heard of that.
So myofascial release, there's two components to your muscle. You have the muscle itself, which is the myo part. The fascial part of myofascial release is the fascia. All of your muscles have a coating, a covering that envelop them. And it's not a tissue that you can actively tighten or loosen just by thinking about it, but you can do that with a muscle. And sometimes that fascia tends to tighten or get restricted or have adhesions that develop between layers of those. And so in physical therapy, we can use our hands with massage techniques, with light pressure to help release that system and give you the most extensibility, most flexibility that is possible for that. Any other questions? Any other questions about additional things that you can do outside of physical therapy, injections, exercise, anything like that? All right. So thank you very much for having us come out today. Again, both Dr. Rawal and I will be available here after if you have any individual questions that you would like to talk to himself or myself, and we'd be happy to answer those. If there's something that you would like to get looked at, I also do free injury screens. Just call the clinic. I have cards available over there. You call the clinic, and it's a 15-minute free consultation where we can kind of just run through what's ailing you and get a plan. Maybe physical therapy isn't the thing for you, and maybe we need to get you over to see Dr. Rawal. sooner rather than later, and figure out a different path for you, or maybe you just need a stretch to add into what you're already doing. Okay? All right. Thank you very much.
Is there any questions that you guys have for me?
Yeah, I have a question. Why do women get arthritis more than men?
I don't think there's a great answer for that.
Well, my friend said because we do more.
Probably. That's what my wife would tell you too.
That's what we would have.
Yeah. Yes, sir.
How in any way does diet have anything to do with it?
So,
Are there peoples in other areas of the world that just don't get arthritis? That you know of, right? Et cetera, et cetera.
So, I mean, there's the whole realm of functional medicine that looks at, one of the main things that can be causing potentially many of our ailments is just general inflammation. So that general inflammation can cause problems with our GI system. It can cause problems with our feeling brain foggy and our memories not being well. It can also affect our joints, etc. So, excuse me, there's a movement out there in general of how do we decrease that overall body inflammation. So, I mean, we know that there's natural foods that tend to be help as anti-inflammatory. So, people will add, functional medicine doctors will advocate taking things like turmeric, which is standard part of cooking in many other cultures as well too. And there's other dietary things that are anti-inflammatory type things. We also know that certain foods that are part of our regular, what we call the standard American diet, that tend to be more pro-inflammatory. So a lot of the carbohydrates, we see people who feel that they have a certain sensitivity to gluten, and so they may cut that out of their diet as well and may feel better from that. There's all kinds of other things too that can cause inflammation as well too. Could be in our home environment, etc. There can be things like if you're constantly exposed to maybe an animal that you have an allergy to but you don't know. Could be if you have something like mold growing in your home that your body's immune system is trying to fight that with inflammation. So there's a lot of different things in terms of that, and there's a lot of great resources that you can find online in terms of just trying to improve all that from a diet standpoint to not just help your joints, but a multitude of other just health concerns that a lot of people tend to have.
Good question.
How does the body change its oil?
How did the body change its oil? So the lining of all the joints is called the synovium, or inside has synovium, and that's the tissue that makes the joint fluid. So there's a combination of that lining will absorb old fluid and make new fluid, so it replenishes itself. Yes?
My chiropractor says that diabetics, which I'm one, tend to have more problems and stiffness in joints and tendons. Do you find that's true?
In some cases, yes. When we see people, like for example, I see people with, say, for example, frozen shoulder. That's a condition where, for reasons we don't know, people get inflammation of that lining of the shoulder joint, and that becomes thickened, contracted, and inflamed. And the main thing that you see with that is that you lose your range of motion. We see that more often in diabetics, and that becomes potentially harder to treat in people who are diabetic. So, there's so many multitude of things that diabetes affects, in terms of overall healing, potentially joint mobility. We know kidneys, vision, and then neuropathy that you can develop. So we know that's it's a very silent disease because many of its effects are things that we don't necessarily notice up front and can slowly creep up on you. Well, thank you again, everybody, for coming out. I appreciate your time. One more question?
Does neuropathy affect your balance?
For sure, absolutely. So neuropathy, you tend to lose the ability to feel on the bottom of your feet, and it can affect your hands too. But most commonly, I think that it affects most people is when it affects the bottom of their feet. There's a lot of different input that goes into your balance system. Your inner ear is one of them, your vision is the other, and then just your feedback system from your joints and your skin, the sense of touch. And when as we age, we know that our inner ear tends to deteriorate a little bit, leading to some of that balance. Our vision may tend to deteriorate a little bit. And then the development of neuropathy can be kind of the third strike against you as far as balance goes. And we don't have those feedback systems all working well together, then that leads to some of our balance impairment for sure. All right.
Again, everybody.
All right, thanks again for coming.